Ever wondered how two totally different diseases might look almost the same? Let's unpack. Welcome to Path Chat and Chai. Thank you so much for stopping by. Today we're breaking down a classic mix-up so you'll never confuse them again. Grab the beverage of your choice. I've got chai, and let's chat. Okay, friends, let's start with an example. So this is a 9-month-old girl who presented with respiratory distress since the age of 2 months. The mother reported abnormal chest movements and multiple episodes of choking while feeding. So a part of workup included a CT chest, which showed a large multiloculated cystic lesion almost occupying the left thoracic cavity, most likely arising from the left lower lobe with a mediastinal shift. Now, a good point or area to start with when working up these cystic lesions is to answer whether they are real cysts or not. So once they are real cysts, you can use these very handy algorithm to come up with a differential diagnosis. So if it is a real cyst, the next question that needs to be answered is whether it is solitary, localized, or multifocal and diffuse. And in our patient, most likely it falls under solitary and localized. The most likely differential here would be a congenital cyst lung disease, and the radiologist raised the possibility of congenital pulmonary airway malformation. The decision was to resect the specimen. We received the specimen and submitted sections. This is a section from the cystic cavity. You can see here there are some dilated spaces with the cavitary wall or the cyst wall showing edematous changes. The lining appears to be low cuboidal to flat. Another area here showing again cystic cavities with the cyst wall showing edematous stroma and the cyst lining being cuboidal to low columnar or even flat. So at this stage, you might be tempted to call it congenital pulmonary airway malformation, but here you need to pause and additional sections and extensive sampling will be your friend. So let's look at those additional sections. Okay, so let's look at those sections from the cystic cavity over here. So this is a representative section of similar to what we saw in the still images. So you have the cystic cavity with the edematous wall, and you have the cuboidal to flat epithelium. However, let's look around. It's a big section and we had multiple cysts. This area captures your eye. It's more cellular, more busy. And the cystic cavity, again, the lining with cilia over here. But look at the underlying stroma. There is a proliferation of atypical primitive looking spindle cells with high NC ratio. Uh, Over here, and then some of them have this eosinophilic tailing to them, then over here again, so you have these lining of columnar epithelium and then proliferation of these atypical primitive looking spindle cells hugging the epithelium almost like a cambium layer that you see in some childhood sarcomas. In other areas, as you can see here, that you have the myxoid stroma with the spindle cells, but you have other spindle cells with eosinophilic tail and striation to them. Some areas have these rhabdoid differentiation, so abundant eosinophilic cytoplasm with eccentric nuclei, and then again you can appreciate the faint striation to those cells. Again, if you go around and you start looking carefully, you see more and more of these mesenchymal looking or primitive looking atypical cells with hyperchromatic nuclei, and then you see the striated spindle cells and other areas showing you those rhabdoid differentiation. So let's take a look at the still images from the same lesion as we saw in the scanned images. We saw the epithelial lining, which is more columnar and underlined by these atypical spindle cells, primitive looking, mesenchymal, and then you have the other spindle cells with tail cytoplasm and striation, even some rhabdoid differentiation. So this is a closer look at the atypical cells, high NC ratio, undifferentiated, blastema-like cells, spindling over here, and then you have the rhabdoid differentiation and the tail tadpole-like spindle cells with striation. So some of the immunohistochemical stains that we would recommend is definitely Desmin. You want to confirm that they have a rhabdoid origin, skeletal muscle origin. So Desmin shows positivity within the high primitive looking cells as well as the cells with the tail tadpole cytoplasm and the rhabdoid areas as well. Myo D1 was positive, myogenin was positive. So if we put everything together, we have a young baby who presented with a cystic lung mass, and sections showed epithelial cystic spaces with epithelial lining and with underlying primitive looking atypical mesenchymal cells, high NC ratio, Desmin, myogenin, and MyoD1 positive. So the differential diagnosis was pleuropulmonary blastoma, most likely type 1 because it's mostly cystic. We recommended that the patient be screened for DICER1 mutation, and indeed the WES test came back positive for mutation in DICER1 gene. So next, I will touch upon the high points in differentiating CPAM from pleuropulmonary blastomas. So if you recognize this gentleman, comment down below. This is Morgagni, cysts of Morgagni, and who was the first to describe pulmonary cysts. And let's start by defining pulmonary cysts. These are round parenchymal lucencies showing a well-defined interface with normal lung in the absence of emphysema. There are air-containing spaces surrounded by a thin wall. Usually the walls are less than 2 millimeters up to 4 millimeters. The cavity, in comparison, is described as an air-containing space with a pulmonary consolidation and a relatively thick wall of more than 4 millimeters. It's usually surrounded by a mass effect or some kind of consolidation. So this is a cyst, and this is a cavity with thick wall. Now, as a differential diagnosis of air-filled lung lesions, you can refer to this handy table where you can look at the different definitions. And then, so for example, these are the cysts of Langerhans cell histiocytosis. This is emphysema. This is honeycombing, and this is bronchiectasis. So grossly, as you can see here, there is consolidation in the background, and this is an example of a cystic cavity secondary to an abscess, and these are cysts with thin wall lining the cavities. Just like in the radiology, I think this is a very handy algorithm that you can refer to when you are working up a cavitary lesion, cystic lesion, or air-filled lesion. So the first question you want to answer is, are these real cysts? Once you have reached that these are real cysts, the second question is, are they systemic localized, solitary and localized, or they are multiple and diffuse? So let's focus on Like, for example, our case, this was solitary localized. The differential diagnosis would either be incidental cyst or congenital cystic lung diseases, since this is from the age of 2 months old. It's in a pediatric age group. In the pediatric age groups, three main differential diagnoses that you would consider would be CPAM, sequestration, and bronchogenic cyst. Let's concentrate on congenital pulmonary airway malformation. These are composed of solid and cystic mass of pulmonary tissue, historically subclassified into 5 categories from 0 to 4. However, the type 0 and type 4 are now obsolete. Type 0 is referred to as SNR dysplasia, and type 4 should be considered as pleuropulmonary blastoma. An honorable mention to an example for a CPAM type 1, as you can see again, dilated spaces with a cyst wall and the lining of a columnar ciliated epithelium that might closely resemble pleuropulmonary blastoma. However, if you are thinking or your differential diagnosis is a type 4 CPAM, and this is an example of a patient with a CPAM again, you have to examine very carefully, as this term is obsolete, and you need to document if you have other atypical mesenchymal element. So again, as we mentioned, you have huge dilated cystic cavities, you have the epithelium, and underlying the epithelium, you will find the proliferation of spindle mesenchymal primitive looking cells, which will be positive for myogene and myodesmin, myod1 and desmin, and you can have rhabdoid differentiation. So what are pleuropulmonary blastomas? These are rare malignant tumors, mesenchymal in origin, arise in lung and pleura or mediastinum. 70% of them harbor the DICER1 mutation. So the DICER1 mutation implies a predisposition syndrome, which is a DICER1 syndrome. It is a rare autosomal dominant tumor predisposition disorder with heterozygous DICER1 germline mutation. Most common tumor that are seen in this syndrome is pleuropulmonary blastomas. However, you can have many other neoplasms ranging from cystic neoplasms of the kidney to neuroepithelial neoplasms and thyroid neoplasms. They can be divided into 4 subtypes. Type 1, which is the cystic, predominantly cystic, and you'll have the atypical cells lining the epithelia, just like our example. Now, another type or subtype is type 1R. R stands for regressed. So now during the DICER 1 screening, multiple familial cases were identified, and relatives of patients with pleuropulmonary blastomas were found to have cysts but never developed sarcomas. And histological examination showed cystic cavities with columnar epithelium, however, no mesenchymal, atypical rhabdoid cells were identified. So these were considered as type 1 regressed cysts. Type 2 is a combination of cystic and solid sarcomatous tumor, and type 3 is entirely a solid sarcomatous tumor. You might have, other than rhabdoid differentiation, you might have some chondroid differentiation or other sarcomas. Now, the treatment for type 1 is usual surgical resection, a complete excision, and no radiation is needed. Type 2 and 3, surgical resection if possible, and adjuvant chemotherapy. So again, as you saw, we concentrated today on this part of the algorithm where we differentiated CPAM from pleuropulmonary blastomas. However, if you are interested into looking into the rest of the differential diagnosis, comment below, and maybe we can create a series discussing the rest of the differential diagnoses. Now it's your time to chat. Let me know what you think in the comments below. Stay curious, keep learning, and enjoy your shy. Until next time.